Thank you very much, Ian. I must say I'm thrilled to be part of this wonderful conference. I must apologize for my voice, which is in danger of leaving at any second. Obviously, I don't wash my hands often enough to prevent every rhinovirus. I don't think there's a person in this room who doesn't know or doesn't live that we are in a time of great change in the health system and in public health in Ontario. And I think whether you embrace it, resist it, moderately skeptical, or downright really don't like it at all, I think it's going to be very valuable to us to hear from two leaders, provincial leaders, about this change, what it means for their work, what it might mean for our public health system and for the health of Ontarians. First off, Dr. David Williams will speak to his priorities as Chief Medical Officer of Health within that transformed system and in the process of transitioning there, including those articled in Mapping Wellness, Ontario's Route to Healthier Communities, his just-released 2015 annual report of the Chief Medical Officer of Health to the Legislative Assembly of Ontario. And in case I forget, congratulations, David. I know it's a mammoth piece of work and well done. Next, we'll be fortunate to hear from Assistant Deputy Minister Rahzel Martino, who will highlight progress since the passage of the Patients First Act. Certainly, you'll get a little glimpse of how many moving parts Rahzel is trying to not just juggle, but move forward. So she'll speak to the public health work stream that is defining the formal engagement parameters between LHINs and boards of health. The expert panel on public health that's providing confidential advice to the minister on structural and organizational factors that will improve the integration of population and public health into the health system and improve public health capacity. And as if that weren't enough, also on the renewal and modernization of the Ontario Public Health Standards, which have been released and they're currently in the consultation phase. Following that, there will be an opportunity for questions and answers, which will be after both speakers. So if you think of things as you're going along, if you want to note them and then come up to the podium at the time. So I'm going to get started with Dr. Williams. So David was appointed as the province's Chief Medical Officer of Health last February 2016 after many years of service at the local and provincial level. He has served as Interim Chief Medical Officer of Health, as Associate Chief Medical Officer of Health in various capacities. He has had long-standing service to the Thunder Bay District Health Unit for two separate periods. He is a 4-time graduate of the University of Toronto. I think that should give you some kind of special gown you wear all the time, David. But having received his BSc, MD, Masters in Community Health and EPI, and Fellowship in Community Medicine and Public Health and Preventive Medicine from that institution. Prior to entering public health, Dr. Williams practiced hospital-based clinical care as a GP and GP anesthetist at Sioux Lookout Zone Hospital and also overseas in Nepal. David, we welcome you, I welcome you, and want to hear what you have to say.
Well, thank you, Valerie, and it's great to be back again, and want to congratulate Public Health Ontario, Alpha, and OPHA for another fantastic conference, and for all of you for coming. So far, it's been a great opportunity and networking, and so I've really appreciated it. It was about a year ago, I was here last time, just after I was appointed, and I talked to you about a number of things. I'm not going to talk about my mother's spring renovation things again, so you don't have to worry about that. But I did invite you to join in the ongoing work of transforming and taking us through public health in the province of Ontario. And the work that came down originally to assist Dr. Sheila Basra, and of course the center is after that name. And we started that path long ago. And that path has been moving stalwartly forward over this past year with the announcements of Patients First. And I must say it's been a great opportunity to work with Dr. Robert Bell, who's our Deputy Minister, who opened up on Wednesday, and then also working with our Minister, Dr. Eric Hoskins, over the last year and coming to work on the different aspects. And it's been a busy year. There's been lots going on, and you're going to hear lots of updates from Rahzel. And, excuse me, I've got the cold too. And certainly I must congratulate Rahzel. It's been a very busy year for her. This tumultuous task of taking the Public Health Division, the Health Promotion Division, and bringing them together and all the structure in that. Having been through that before, I can tell you it is a pile of work. And they officially completed that at the end of October. And now everybody's finally found out where their desks are and moving that. And so I'm looking forward to the synergy of the two back together again, that when I came down and assisted Sheila and we were split, we were lamenting that at that time. So this has been a great aspect there, and so congratulations to Rahzel and her team and her directors on this work. And also, of course, all the work on what you're going to hear, she's going to speak on that I've had a part in, but I'm going to let her cover that because time is limited. Now, in that aspect there, with the change we're trying to take forward on, with the modernization of Ontario Public Health Standards, the work streams, other things you're going to hear about, is a really great opportunity for public health in the province of Ontario. And I'm pleased to say that certainly that's carried forward by the Deputy and by the Minister, who sees us well poised to step forward and up to this task. And in the modernization that you're going to be hearing from Rahzel and with the consultation taking place, it gives us a chance to delve into aspects around population health assessments and allowing you the capacity to step up and do what you need to do in your respective jurisdictions. And while some find this a bit daunting, some find it really exciting and a great aspect of public health that they felt has been missing for your role to assess, to work with, coordinate, and communicate, and to work on your programs that are specific for your areas. And I think this is added to that with our working with the local health integration networks and the aspect of working with an integrated health system, not just a health care system. And I'm not going to cover that any further because I think it'll be covered anyways. With that in mind, when we sat down to look at the annual report, and this is my second report since returning, it's actually my fourth one, because when we looked at the reports of the CMH to the legislature, what is the value and function of the CMH report to the legislature? Reporting on a significant aspect of the health of the public. And we want to make sure that they had traction. So last year's report on immunization was to emphasize and work along with the division and other ones with Immunization 2020. And those recommendations and still pushing for those registry, virtual yellow card, and many other components continues to drive and move forward. At the same time, we wanted to make sure that the reports were more accessible to the public at large, spoke to the public, were not just an academic document with family photos and stuff that got buried on shelves and never seen again. And as a result, we've looked at the report again this year, and this started back a year and a half ago with my predecessor in the acting role, Dr. David Moe, had started to look at some of the chronic disease indicators. And this one goes on the other side from health protection. Yes, there's more than health protection. And much like that, we sat down and said, we're looking at indicators of chronic disease, and he was trying to do a review of a previous report by Dr. Arlene King. And what surprised us when we had some of our people review the data is that not much had changed as far as access to data and new data on those regards. And to me, this was concerning. So this year we sat down, we said, what do we want to emphasize and work on at this time here? So you can see on the screens the title of the report. There are hard copies of the report on the front two tables over here, as well as a one-page summary that gives the highlights and points of the report, and it is available electronically. It has been tabled to the legislature, and so therefore is out for public consumption at this time. When we sat down and looked at the issue, it was very critical and very important to us that in this whole transition process, we have to equip you with what you need to do the work that you're being asked to do. And part of that challenge is that do you have the information and data that you can map forward on to engage in the various settings that you're going to have to work on, and you have the opportunity, and I know the passion and desire to work on as you go forward. So as you can see here on the mapping things and mapping forward, I'm going to switch slides here. The purpose of the report overall, as you can see here, is we're trying to look at the aspect of community. And this is a great point right now of where we are in our current setting, because our society with social media and with technology, and I've been reading Friedman's book on Thank You for Being Late, it's impacted me with how much the technology has raced ahead of our structures and ability to apprehend and deal with that information. As a result, we have more and more people connected to more and more information, but more isolated than ever. And this leads to an increasing level of anxiety and concern among our members, and isolation that is actually making our marginalized populations, our elderly, our disabled, even more marginalized. And much like I've had the benefit of working with a lot of the last 5 years with our First Nation partners in the Sulakaut First Nation Health Authority, understand those values of the First Nation, Indigenous peoples and their king, the value of community and the value of wellness in the community. And so we did focus on that aspect here. As you can see on the report, we're trying to focus on the key aspects of investing in community wellness. What do we mean by community wellness? A lot of our people don't know what they mean by public health, and also improving our public health data and connecting with our public in that matter. And so as a result, you can see here, we tried to combine in the report taking some aspects around what is that data, what is community wellness, much like we do with personal, because people these days, including my Fitbit, are very interested in their personal data. They're very suspicious of evidence these days, and we're losing that. I'm not meaning about alternative facts, and we hear that common sense word there, but they're very concerned about the evidence. They're not sure about RCTs. We are, they're not. We're not sure about studies, because one study says left, the next day it says right. And so we have this confidence loss in our public. But they do like data, but they like data that applies to them. And what does that mean to them? So how do we get that data close to the local source, as I've noted here on the slide deck? We then try to take that concept and that idea, look at examples of how some of our health units, and many of you are all doing it. We picked 4, that being Sudbury, Niagara, Durham, and Toronto. Only 4 of the examples that I know that many of you are doing some excellent ideas in that area. And we put those in there because the public need to read some of those stories of how it can help them in their different components. And you can see here that then, out of that aspect, we were concerned about how do we connect with the public in that regard. And, sorry, my slide there. And how do we improve that population health data? We realize that a lot of the data points you have to look at, some are 5 to 10 years old. That does not resonate well with the local community. Some are dealing with areas that are so far away from them, they say, that is not our data. And so then, how do we enable you and equip ourselves with the materials we need to go forward with in that regard? I know the example of the Sudbury District Health Unit on this slide here. Following up on that, how do we connect with the public? And you can see here that if we have that data and we have that information, much like I experienced as the medical officer of health in Thunder Bay, when we had an issue in a small town community, we did a survey, and while they knew their community intimately, they didn't know it that well. And when the data was presented to them, it confronted them with the issue at hand, and they owned the issue, and they decided to take some action and to deal with that issue. That empowered the community to move forward with an issue that they had not been aware of, and they had their own solutions, and it empowered other actions in the future as they stepped up to the task. So can we get the data sources with enough down to your level that you can deal with it at the health unit level, the LIN level, the sub-LIN level, even down to the neighborhood level? Because we're aware, and you're aware in your studies, is that what we're dealing with in Ontario is an increasing level of disparity among the health of our citizens. And we used to have the model, the Rose model, the whole bell curve moving, and we've moved the mean over on a number of things, our age expectancy and the rest of that. We have been successful. But maybe the whole curve has not moved. And do we have a long tail? Do we have other blips that we're leaving groups behind while we move the middle and upper class and other groups along that way? How do we identify those groups? Because in some studies and areas, we know that there is up to sometimes 400 to 500%, even 1,000% difference between adjacent neighborhoods in certain morbidity and mortality data. So then we need to take that and connect with our public group. If you look at some of the other examples we've done in here, we've given you some ideas of Durham and how they've used it. So we have an example in the report of how Niagara has used it to deal with an acute issue, Sudbury with some disparity issues, Durham with a variety of different issues, and you'll be able to see that and read that in the report. I will start with an apology at the report when you get the hard copy. As always, there's those last moment errors and mistakes. Usually it was in the spell check between public health and pubic health. This didn't happen this time. I've had many of those already. But this time, of course, it's with irony. When they did the map in the hard copy, they showed the old boundaries, and it's the Thunder Bay District Health Unit wasn't shown correctly. Of course, it's ironical. We got the correct one in the electronic version, and you can look at that. So apologies to Dr. DeMille and members of the Thunder Bay District Health Unit. I do know what the map does look like. And here's some examples from Durham, and here's some recommendations for the province. And I know my time's going to be up shortly. I'm waiting for the sign. What do we want to do with this? One is that we need to understand our communities better. It's always been valuable for Canadians and Ontarians. We value our communities. We value what they mean to us. And we value the things that are in there. But with our rapid-paced society and our mobility in that, sometimes we're losing that. I have to listen to whether it's the communities, the rural, remote communities, they really value the sense of community. Even in Toronto, in the various parts, you hear them talking topically on the news and media about community. How do we reinvest in community? How do we make community? That adds extra added value to us. How do we build those things in there so that our people in our community do not have to fall into the healthcare system when they don't need to? But some have no access, some have no resources, and how do we handle that? So therefore, how do we understand our communities better in that aspect there? And then I've written down there, how do we share with our communities? How do we invest in our communities? And this is where you have the expertise, because you can take the data and you can work with that, and in the dialogue with our community partners. And communities, it's a matter of definition. We've always talked about individuals in the family context, the changing family context of what it is today in the communities that are changing. These can be communities geographically, these can be communities ethnically, these can be church communities, religious communities. There's many different versions that people look at and depend upon each other for those little bit they need to maintain their independence and not become patients of the system necessarily and add to the extra cost and burden of the healthcare system. So I think that by investing in our communities with small amounts, can we nudge that issue of disparity and move the yardsticks on that one here. So there's one of the challenges I'm putting that one there. And if we look, so I slip one slide here. I want to then mention there, so we want to, one, understand our communities, the data you need to do, so invest in the data systems. We looked at the data systems, they're patchy. 10 years ago, post-SARS, we entered this thing, we spent a long time over the last 5 or 6 years in Operation Health Protection to invest in systems that improved our health protection services. Our health promotion side has lagged. We need to invest back in that again to give you what you need to do and to give the communities what they need to have to understand that. So we need to invest in that, we need to share it with our communities and strengthen our communities to deliver on that. So that's the report for your consumption, for your use, and we hope out of that recommendation to the government that we'll move forward in a go-ahead process to deliver on those things in the near future. So I'm optimistic on that. I want to mention the acknowledgments. A lot of work went into the report. The approach you will see is a different formatting. It has much more graphic. It has much simpler language stuff, not a long scientific academic document. It's meant for public consumption. And it has much more storytelling and much more simple graphics to catch the attention and will the public engage in that discussion. So here's an acknowledgement of those who have coordinated and helped on that. I've put the health units down there. I forgot Peel, apologies again, and Halton. And we already had lots of input on that. And so that ends my topic on the report. Am I within time, Ann? 2 minutes, thank you. I got a couple minutes to summarize. So from those priorities there, I just want to end off. Besides getting the report out, and we're starting working on the next report, it's been a big year of transformation for us at the Office of the Chief Medical Officer of Health. We became actually, in reality, a new division very shortly, recently, with the declaration of the new PPHD, the Population Public Health Division, in the end of October. And as I said last year when I came, I was an office of one, but I did get staff. And so besides my 4 ACMH positions, we have added a manager, Jillian McDonald, and I have other staff, so we're now up to a collection of almost 5 or 6. I've added Dr. David McEwen, who came out of a long retirement of 6 weeks, to assist me in doing a portfolio in areas of work there, and also Dr. Fiona Comey-Midgen, who is helping on some other aspects. So we continue to grow the office up and connect with all the rest of the people there, building strong connections with Public Health Ontario and with the other members around the Ministry of Health and Long-Term Care, and most importantly, trying to get out and trying to connect as well with you, with the field, because you're one of our huge resources, one of my huge resources, because I've always said Ontario, we have rich expertise and resources right here in Ontario with the number of health units, with the number of staff. I only see that through the transformation process and Patients First, we will make an impact, and I feel confident you can do that. Our challenge is to equip you with what you need so that you can deliver on that. So with that, I'd like to say congratulations on another conference, a great year ahead. Stay with us in the change process. We want your input, we want your critique, we want your expertise to drive this forward, because it's opening the door for you. And I think it's a door that certainly our deputy and our minister feel confident that we can deliver on. So again, that's what I have to say this afternoon, and I'll hand things over back to Valerie. So thank you.
Thank you very much, David, and we'll look for questions related to your said and your report later. So I was looking a little bit at the title of the theme for the conference in terms of global challenges and local solutions. One may perhaps find a bit of a parallel with our colleagues here from around Queen's Park, in that perhaps they have provincial challenges for which we may help them with local solutions. But I think we're very lucky in that both these people are also very grounded in local public health. And to a certain extent, they seek to find provincial solutions to our local challenges. And for that, we are grateful to them, although we have funny ways of showing it some of the time. So it's my great pleasure now to introduce Rahzel Martino. As Assistant Deputy Minister for the Population and Public Health Division, Rahzel is responsible for leading policies, programs, and legislation related to population and public health, including transformation, disease prevention, protection and enforcement, performance and accountability, and emergency preparedness and management. Rahzel holds a Master of Health Science from the University of Toronto, and she has extensive experience in the private, hospital, and municipal government sectors, including local public health, and I believe that she came to the ministry with Dr. Sheila Basra from Toronto Public Health a number of years ago now, as well as international experience in Her Majesty's government in the United Kingdom. As mentioned, Rahzel is the policy lead for public health transformation. Her other key accomplishments in recent years include the integration of children's low-income dental programs across government, modernization of Ontario's immunization program, leadership for the health sector response to Ebola and the Pan Am Games, and health system preparation for Syrian refugees. I know she has a lot to say, and so I'm going to give her as much time as possible. Rahzel.
Thanks very much, Val. I'd like to echo David's congratulations and thanks to OPHA, PHO, and Alpha for this Congress. I'm really pleased to be here. I caved when Anne Samard called me, so if you guys need me to do something, you know to call Anne and get her to ask me to do it. The title of my presentation, I'm here to talk about public health transformation, as Val said. The title of my presentation is called #Context is Everything, and hopefully you'll see why in the next few slides. Okay, so most of you know public health transformation is anchored in Patients First, and just a reminder, these are the 5 goals of Patients First, one of which is the stronger links to public health. So I wanted to take a bit of time today, though, to recap why and how we got to where we are today. And this is in a large part due to the number of queries and questions I've received lately regarding the context for public health and patients first. Some colleagues want to better understand the context as opportunities are arising. They want to ensure they're leveraging those opportunities appropriately. Other colleagues want the context to support change management for themselves, their staff, or their organizations. Val certainly made the point about we are absolutely in the midst of change. Others want to know why public health is even part of Patients First, as it is really all about patient care and has nothing to do with public health at all. And of course, there are those who are wondering if there is something insidious going on. And this is really about public health being subsumed by the lens. So those are just the nature of queries that I've been getting and the discussions I've been involved in. My favorite query was from a public health colleague, well known to many of us, but shall remain nameless, who said, "Rahzel, I'm old. I don't know how long I have on this earth, but if public health is going into the lens, you better tell me right now because I need to change my bucket list." I'm sure you can pretty much figure out who that might be. Okay, so I thought it would be helpful to provide the policy context in which I'm operating in. Val indicated that I am the policy lead for public health transformation in the ministry. So I thought it'd be helpful to tell you the story from my perspective, as there are policy parameters that guide the initiatives I'm leading and the corresponding deliverables. So when Minister Hoskins became the Minister of Health, the ministry mobilized to develop a comprehensive policy agenda to support the minister in achieving his mandate. That's standard practice. One of the things the ministry focused on as part of this process was identifying and addressing the key drivers that were contributing to the complex systemic issues so prevalent across the province. As you know now from Patients First, two of those drivers were access to primary care, and not just attachment to primary care, but being able to see your primary care provider when you needed to, because if this wasn't happening, people were turning up in the emergency department. The other driver, of course, was access to home and community care services. And again, because without access to appropriate and required home and community care services, these people were also turning up in the emergency department or frequently being readmitted to hospital. Now, much of this was a result of where provider services were available and distributed across the province. So to address this, the minister's vision was, let's start with patients first and build an integrated system that is easy for them to navigate as they progress across the ages and stages of life, no matter where they are in the province. And that, as you see today, is indeed the essence of Patients First. But that was the birth of the policy concept of Patients First, and I was fortunate to be part of these discussions very early on. I did go to Cabinet and all the policy committees with the ministry, me and some of my other colleagues as well. So, I was there when all these conversations were unfolding inside government. So this is, again, my perspective that I'm conveying to you. So, to me, the minister's vision that I described is a very different policy context than this being only about patient care. Sure, addressing the access to care became a priority policy activity, but the policy intent of Patients First is much broader. So now you know, and all of you are included in this, we have a very committed workforce across our health system. And many of them were not going to wait for ministry policy direction to look at these, big system problems. And they were already working locally to address some of these systemic issues in their communities. Some parts of the province were demonstrating real progress. And what became increasingly apparent is that public health was part of and contributed to these success stories. The ministry heard that public health partners demonstrated that using population health assessment to better understand health status and health needs led to better planning, prioritization, and distribution of health services. Public health helped our other health system partners understand the impact of social determinants. That health equity is not the same as equal access, and that care pathways are significantly influenced by many factors outside of the acute care system. So as health system partners were grappling with very complex problems, the significant value add of public health really shone through and demonstrated the importance of public health having a voice in the broader health system discussions, consistently across the province and in a formal way. So that is why public health was included in Patients First. So taking that concept now, the key policy objective that I'm working on, so these are now my policy parameters. Public health is a sector with unique functions and expertise within an integrated system, because the minister is looking at an integrated system in terms of Patients First. So I'm going to talk to you about sort of the policy context or policy parameters in which is shaping the work that I am leading now, and we'll come to more detail. Public health is uniquely situated and locally with partnerships, access, and influence in sectors outside of the health system, which have a direct and indirect impact on the health of individuals and populations. Core public health functions are not eroded, but where appropriate, leveraged to support reorientation of the health system. The value and work of public health contributes to and supports the sustainability of our health system. Sure, we can do lots of things on the acute side, but we also have to remember there's a whole upstream side that we cannot ignore and have to address. Emphasis on functional integration, population health assessment and integrated planning, or an integrated approach to planning and delivering services. This does not require or imply structural integration. Capacity to support planning and delivery of health services should be considered with a system lens as well as a sector-specific lens. And finally, public health is part of the broader system planning discussions, enabling public health to identify, influence, and leverage opportunities. I gave the example there of other funding possibilities. The reality is there is funding in the system, right? It's about how we distribute it. So it's about having public health at those tables to be able to make the case for why perhaps that money needs to be distributed differently, and identify other potential funding sources as well. Some of the key policy enablers that I have to keep in mind that's driving my work, I've given you the policy context, but some of the key policy enablers that I am also using. Evaluation. So here I'm talking about broader system evaluation. Obviously, we want to look at Patients First from a system evaluation perspective. Is the policy doing what's intended to do? Are the changes that are being made, are they the right changes? Are they having an impact? So that's a big system evaluation piece. But there's also sub-evaluation components to this. So for example, there is, or there will be, an evaluation plan for the new standards, for instance. Research, surveillance, and monitoring. It's important that there's a comprehensive plan that supports a coordinated approach to these activities. Accountability. This is about having the right accountability mechanisms in place to demonstrate value for money and good use of public dollars. And finally, transparency. Public reporting should be meaningful. There's no point in putting data out there for the sake of putting data out there. So what data or information does the public want to have, and what data or info would be helpful for health intermediaries to have? Okay, so I've given you the policy context, I've talked to you about the policy enablers, then I had to take those big pieces and translate the key policy objective of public health being a unique sector within an integrated system, and take the policy concepts, and they became 3 streams of work, what we call policy activities. And they are, what is the work of public health in Ontario? And that is what the modernization of the standards is looking at, or has endeavored to look at. What is the role of public health in integrated planning? And this is the work of the public health work stream, which I'll speak to in a moment. And how does public health need to be organized across the province in order to function effectively as a sector within an integrated system? And this is what the expert panel is looking at. So these are the three main streams of work in the policy realm that I'm leading with respect to public health transformation. Okay. Modernization of the Ontario Public Health Standards. So all of you have received, hopefully you've seen, the consultation document. I recognize that is one piece. It is one piece of the jigsaw. It's a big piece, but it is only one piece. So we do have a plan in the ministry for the other pieces, and this is our overview. It's not all the pieces are done, but I'll just talk you through it a little bit. So obviously you have the standards there. I hope you can see the slide. You have the standards. So the standards, of course, will have protocols, guidelines, program outcomes, and contribution to population health outcomes. This is all from the standards document. The program outcomes and the contribution to population health outcomes, there will be indicators associated with those two pieces. And then if you go to the left side, there is an accountability framework. I'll give you a process update shortly on this. Accountability framework that has requirements. Those requirements will either be indicators that will look at compliance, monitoring, performance, etc., or they might be a metric, such as an attestation. And the indicators that are for the program outcomes and the contribution to population health outcomes, they may or may not be the same as the indicators that we're looking at with respect to compliance, monitoring, and performance. And of course, on the very far left side, we just point out that there are going to be templates for reporting documents, planning documents, how health units submit their budgets. All that is part of the new accountability framework. If you go to the right-hand side, there will be a surveillance and monitoring strategy for all standards as well as each standard. There will be a coordinated data backbone because there's going to be different data sets for each standard. We are looking at centralized data collection, analytics, and distribution. And of course, this is important as we look at a coordinated approach to public reporting. You see that there's going to be a coordinated approach to research, evidence, and best practices. There is going to be evaluation throughout, and we're going to update the standards based on evaluation and emerging evidence. So there's going to be a regular schedule of updating the standards. And of course, there's going to be a central repository for evidence, best practice tools, and data. So all the pieces are not done yet. We are still working on them, but I just wanted to give you a sense of that there is a plan for the standards overall. So in terms of the current status, we officially released the consultation document on February 17th, as you know, with presentations to AMO, Health Task Force, and the Alpha Winter Symposium. We've completed 4 of the 7 regional consultation sessions. Written submissions are being accepted until April 21st. And we're meeting with constituent societies and organizations upon request. And there was a web link for recorded webinar, for the recorded webinar that was circulated, I think it was last week. The effective date for the standards is January 1st, 2018. I think most of you know that, which is when implementation begins. I think that's a really key point. We are not expecting implementation by January 1st, 2018. That is when the implementation begins. And what we're doing now in December is what we call planning for implementation. In terms of next steps, we're going to communicate a plan for sector input and engagement for protocols, guidelines, and indicators. Targeted consultations for accountability framework and requirements will begin. I think the first one is going to happen on April 7th, if I'm not mistaken. We're going to communicate our plan for sector input and engagement for templates related to accountability documents, the service plan, reporting templates, etc. And based on consultation feedback, we're going to determine the training requirements and change management supports and develop an implementation plan for these aspects. And details regarding the elements, such as the evaluation plan for the standards, the surveillance and monitoring strategy, those other big pieces, those details are currently being determined, and we will communicate with you on those as soon as we can. Okay, the public health work stream. So the work stream, as you know, is, or hopefully you know, is looking at the Patients First Act legislative object. The formal relationship between boards of health and LHINs to ensure a consistent role for public health and integrated planning informed by population health assessment and public health expertise and intelligence. So I'm just giving you a snapshot of kind of where the work group has gotten to so far, and I'll give you the update of where we're going to go in just a few minutes. So what we're looking at is a minimum set of core indicators, which is based on what public health already does. We're not looking at indicators that public health doesn't collect now. So these are primarily health status indicators. For those, we're looking at centralized data collection, analytics, and distribution. This minimum core set of indicators can be used regionally and locally to inform population health assessment. There may be some indicators that we have there region or LHIN specific or local or community specific. And if there are those ones, those indicators will be determined between the LHIN and public health parties. So you see now we're starting to talk about the relationship between boards of health and LHINs. And that will be used as part of integrated planning. Integrated planning at the regional level is planning and prioritizing health services. At a local level, it's planning and forming programs, services, and interventions. So what we're saying at the bottom there is that public health brings a population health expertise, a perspective, population health assessment, skills, data, knowledge of local communities, partnerships with local communities and sectors outside of health. Public health equity focus articulates and highlights trends and drivers in health disparities, brings intelligence on the social factors that underlie health, disease, and the use of health services. So in terms of integrated planning, public health's contribution will lead to planning and service delivery that is more responsive to local need and includes a health equity lens, stronger linkages between public health and healthcare where appropriate, and a more comprehensive picture of health and the health system and where there are gaps. So in terms of next steps for the public health work stream, a discussion document is being developed outlining guidance on the policy objectives and expectations for population health assessment in integrated health system planning. The document will also reflect the reciprocity requirement between LHINs and boards of health per the Patients First Act legislative objects. So this is not just about what public health needs to do. The LHINs also have a requirement in Patients First. Input from LHINs and boards of health will be sought shortly. And lastly, expert panel. I'm not going to repeat the mandate because I think Val spoke to that in her introduction, but the mandate of the expert panel is there. I'll just say that panel members were appointed by order in council, including the chair, which is Dr. David Williams. He's the chair of the panel. But he's an order in council member versus a CMOH or a ministry person. Deliberations are confidential, meaning that they wanted to have a safe space to have these very difficult and sensitive discussions. So their deliberations are confidential, but their advice and recommendations will not be. In terms of next steps, so the order in councils expire in May, so that will tell you that we need to wrap up the work of this panel pretty soon. No recommendations will be considered without consultation. I think that anybody in the ministry would repeat this emphatically. And of course, we'll be seeking government approvals on what the next steps should be or could be. So that's it for me. I just want to say, really quickly, a huge thank you, a shout out to all my staff in the Population and Public Health Division. The work that I do would never be possible without each and every one of them across all the branches. I don't care what level they're in. They're an incredible group of people, and I'm really, really blessed to have such an incredible group of staff complement not just managers, directors, but staff in the Population and Public Health Division. I'd like to thank Dr. D and the Office of the Chief Medical Officer of Health for his support and collaboration in all this work. And I'd like to thank all of you. As Val said, yes, we are the recipient of a lot of grief and complaints and everything else, but there's been a lot of camaraderie from many of you, and I really appreciate it. Many of you have reached out and said, how can we help? And that's been a really, really important thing for us, for not just for me, but all my staff, because we feel like we're, slugging away, and we really are committed to making this work and making this a positive experience. So really appreciate that support as well. It's a two-way street. Thank you.
Thank you very much, Rahzel. Okay, it is now on. So this is, we have about 15 minutes, I think, for questions and then subsequent answers. If people would like to come to the microphone, I'm going to apologize ahead of time. I may know you very, very well, and I cannot recognize you from anything from this distance with these glasses. So I'll just sort of go microphone this side and that side if that's all right. So while people are thinking and perhaps approaching microphones, I have a question for David. So it's listed as a 2015 report, which antedates a little bit, perhaps not the thoughts about Patients First, but any open publication about that. And in terms of a transformed system, how do you see your reports? Is it specific to that system? Would it exist prior to? Am I kind of making sense? Yes?
Well, I think part of the confusion is when we have these numbers attached, the years. The report is, if it's for 2015, has to be completed by the end of either calendar fiscal of 2015-16 or 16-17. So we've met that guideline. So we have to date them that way correctly. They sort of came in parallel. The thinking was actually before Patients First, as we were working with, and I had some discussions with Dr. David Mowat and with other members at the time of how we would look at this issue. And I guess we were very, disappointed in how weak the data was and how the gaps were, and we wanted to address that. I think the focus getting into the community very much segued well into the Patients First concept, knowing that they're looking at the LIN and the sub-LIN idea. But I know that health units actually already are looking at within individual communities and right down to neighborhoods, because you know where your high-risk populations are, and have tried to address that. And this issue of health equity, people want to go at it and have done their own methods to try and get the data, but that sometimes is costly, and it means an uneven playing field across the province. So it challenged me to say, what do we need to put some things in place so that everybody in your respective jurisdictions can play in that sandbox fairly? And so that was the idea behind putting that concept with the at this time in the report.
Thank you very much. So Rahzel, I know from a number of conversations with you that your enthusiasm for this is quite genuine, and you have lots of experience in public health in different places and at different levels. So what do you see as the greatest opportunity for local public health in the next year, 2 years, or related to this process?
Gosh, I see many opportunities. I think really the biggest one, in my view, and it is a change management piece. It's about public health doing their work a bit differently than what we're used to. But I do think it's about being part of those system conversations, but not believing that public health, that the work of public health, that translates to an erosion, that you're going to stop doing what public health does. But actually see that there's an opportunity there for people have seen what great work public health does, and be part of those conversations to actually truly reorient the health system. I know that is something that's there. It's a core piece of work what I think public health strives to do, and I say this because I have worked locally. But to actually be part of that true reorientation system conversation, I think is the greatest opportunity for public health, not just from funding, but actually influencing interventions and programs. But you really have to rally around and get your head around thinking about that differently and operating differently.
Thank you very much. And Has anybody approached the microphone? If you have, wave your hand. I should be able to detect motion even at 100 yards. But okay, well, I don't see that. So I just have one more sort of general question. So Rahzel, and this is either for Rahzel or David or both. So you started off with your first slide, which was hashtag context is everything. And as you were talking, I pulled up 3 hashtags, and I'd just like you to comment if you think they're good ones or if there's any first, second, and third to them. Hashtag population health, hashtag health equity, hashtag functional integration. Comments?
Val. Where's Peter? She's not allowed to moderate anymore. I guess I would say hashtag functional integration. I think that's a really important piece because as I started my commentary, I know a lot of people are thinking, well, this is about structural integration, and really public health is really, are they going to go into the lens? And I want to make the point that structural integration does not mean, it's not the same as functional integration, and we can look at integrating functions in a meaningful way that doesn't erode public health and doesn't mean that you're, being subsumed by anybody. So I think it's about understanding that construct and thinking outside of the box and being a bit innovative about how that could work. I think for health equity, the only thing I would say there is that it's not the same as equal access, and I think that's a really, really key role for public health to educate and impose and weave into health system thinking, because I think there's a true lack of understanding about health equity on the acute care side of the house.
Thank you. Dr. D.
Same question?
Hashtag population health, hashtag health equity, hashtag functional integration.
Well, as I said, when I was looking at the book by Thomas Friedman, when you have hashtag, of course, that everybody tags on and they put on their likes and dislikes, and you find out they're actually talking about 3 or 4 different things at the same time. And I think part of that is that we get down to those values of what we in public health have around individuals, family, and community. Much like the concept, I guess, was Hillary Clinton used it with, it takes a village to raise a child. And I think that idea about that it takes a community to have a village. And we want to have that idea there. So these hashtag ones, these definitions, is that dialogue with our public to come around that concept. Because I found in discussions, health equity, population health especially, has so many different meanings. Population health now is one of the bandied around terms that everybody likes to use. It means many different things to different people. I think we in public health have to be clear what we mean by that and to be able to do that knowledge translation, not just of the definition, but conceptually, how do we make that work for our public and that makes sense to them so that they can take the data and evidence, and as I said before in my presentation, overcome that lack of confidence they have right now in evidence, because it's been eroded by many different individuals in commentary. We have to come back to those frank discussions, so it's not just hashtagging, it's actually buying into.
Thank you very much. And I'm getting, is there a question?
Yep.
Good.
Hi. Hi, my name is Yasmin Khan from Public Health Ontario. Thank you very much for your comments situating public health within Patients First. I work as a physician at public health, as well as a clinician in the acute care sector. I really appreciate those comments, how you frame public health as obviously from, I guess, the room's perspective as crucial to the population health perspective of Patients First. However, I had a different experience last week in which I heard leaders at my institution in Toronto speaking about the role for hospitals in the, in quotes, population health agenda. And I guess I would ask you how you intend to, as folks who have worked in public health and see the important role for public health in Patients First, how public health can stay at the top of the population health agenda and not get it subsumed under these powerful acute care institutions which already take so much of the health system resources.
Sure. So what I would say there is a couple of things. The policy objective of Patients First with respect to population health assessment was not only specific to public health. It was looking at a number, like population health assessment in the broadest way includes a number of different indicators. So indicators from the acute side as well, like hospital, ED visits, ALC rates, those kinds of things. So there is a role, so even though population health assessment is a core function of public health, the intent of Patients First is to look at population health assessment in a very broad way. So that means that not only public health would be involved in population health assessment. So that's one sort of clarification point or distinction there. What we're trying to do is be really clear on what public health's contribution to population health assessment is. Which then gets to your other point about how do you ensure that public health remains at the top. I think that is a key part of the relationship that is going to be defined between boards of health and LHINs, and how those interactions happen across different layers and different levels of various organizations. I think that is still evolving. We're starting first with MOHs and LHIN CEOs as an example, but that's not going to be the only point of contact. But that's the start of the conversation, and this is going to be an iterative process. As new as it is for public health, it's also new for the LHINs. It's been done very inconsistently and sporadically across the province. So I think that the key thing is having the formal, the legislative requirement that's there, so that they have. I get for public health, it's like, okay, so if we're there, but how do we ensure that the LHINs don't suck every life out of us, and how do we ensure that they actually listen to us, right? They're hearing what we say. It's the elephant-mouse scenario, and it's not going to change overnight. But I think that public health can be a mighty mouse, but they have to be at those discussions. So I would say it's the start of the conversation, and I think the real, consistent voice of public health across the province is going to, as a sector, show the impact, which will enable public health to continue to be part of the conversations. Are you always going to be part of it? Are you always going to, be on the top? I don't know that, but I can certainly say if there's a consistent approach to how public health is interacting with respect to population health assessment and integrated planning, that will definitely increase the potential impact. Thank you.
Thank you, Rahzel. I'm going to take microphone 2, and then, according to Dr. Johnson, it'll be time to move on. Thank you.
Okay, thank you very much. My name is Loy Wiley. I'm a professor of public health at Western University, and I really appreciate the comments you made about stressing equity and talking about social determinants of health and the role that public health can have in pushing that agenda forward. But one of the things I find we're always struggling with is how do we move those resources so we're actually putting those investments into upstream social determinants of health. And just an example I have from London, Ontario, I work with a hospital quite a bit, and we had an example of somebody who was in a mental health inpatient unit that was costing quite a lot, like, over $1,000 a day. They were there for over a year because we couldn't find housing for that person. And so we were spending all this money in the hospital, and it would have been, 5% of the cost if we had just covered that in housing. But it's really hard to shift those resources from acute care into those upstream investments in social determinants, especially when we don't have all of those other ministries on board for a genuine health and all policies approach and an investment into that. And so I'm just wondering, how do we bring that conversation to that level of actually moving the resources, not just the rhetoric, towards an upstream investments? Thank you.
Okay, I'll take a first shot at that one there. Thank you, excellent question. And I think it speaks to when we're starting the dialogue, as Rahzel's alluding to, sometimes we come across with our message that we have our point is right and the other sector, the healthcare sector, has theirs. There's lots of competition for scarce resources, but they're there. And part of that aspect is that when we, having worked in hospitals and been a hospital director, another aspect in the past, when the aspects are brought to around public health and social determinants of health, how do we put it in a language and a context that they can understand? You mentioned the context, the hashtag. And sometimes we're not that good at translating. We like to emphasize the difference between big PH and little pH. We're big public health. We're not part of the public health system. But I think sometimes we don't have that dialogue that we need to have to understand where they're at and how do we translate into the data and information that when I've done that in the past and they can see the issues, they say, it obviously makes sense to do that. And I think sometimes in the past we've had enough resources that we could silo all those issues and stay remote from each other. I don't think we can do that any longer as a society, nor to sustain the health system that they want to hold on to so badly. We have to offset some of the load that's being pushed on them because of the way we've structured things, and people have no choice. The main place to go for care is you run to the emergency department. And even our primary care doctors are going to be involved in the LIN thing. That opens up a whole great dialogue that our primary care physicians want to work with public health because they feel they're a very key part of that prevention aspect too. So we have many opportunities for conversation, but we have to be prepared to listen and understand the context they're at and to give them the information in a way that they will understand. They'll say that impacts us. We understand that. And we're not here to say we're going to try and get at the top of the pack to take it away from you. We're in this together, and if we don't do this right, your system's going down too, in some sense. So we want to make sure we're in this together, and therefore we got to have the conversation together, and we have to listen and speak to each other in such a way to be understanding, not to dictate or pontificate what we know is better than other ones. So I think it's the start of a process, and I think we have a great opportunity for dialogue in the number of years ahead.
Thank you very much, and that concludes our time here. Personally, as moderator, I'd like to thank Rahzel and Dr. Williams. Thank you so much. And you can't have a good presentation without a good audience, so thank you very much for your attention and your very thoughtful questions.
Thank you very much. Really appreciate, thanks Val, Rahzel, and David. I think it's really good to have these conversations, and I know it's a time of change, and I think it's really good to have these discussions. I hope we continue to have them. I want to first apologize to everybody. I got up here and got the lights on, and I never actually introduced myself. So for those that don't know, I'm Ian Johnson. I'm a scientific advisor at Public Health Ontario, and I'm the chair of the TOPHC Program Committee. And I believe that latter part of information is a bit important for the TOPHC game. So I also feel totally out of character in a suit. If those of you who know it, I've been being teased by all my colleagues, why am I wearing a suit? But anyway, I will go back to my purple t-shirt soon. At this point, I'd like to invite the PARC group, the Physical Activity Resource Center. They've been a terrific group helping us. Come on up. With our physical activity. I think they've done a terrific job, and we're here to do an active stretch.
We do. I am the PARC group, again. I hope you're all having a really good conference. I'm sure, end of the last day, and it's Friday. People are almost ready to go, but before we go home, I'd like to do one last activation with you. So once again, if I can get everyone to stand up or sit up, the instructions are up on the slides there, but on your tables, you're going to find a set of stickers, because who doesn't love stickers, right? We may all be professionals, but let's be honest, we love stickers. So these are samples from our 50 fitness activities. I want you to pick a sticker from that nice sheet and stick it on your shirt, your coat, your sleeve, anywhere that it's easily visible. Make your choice carefully now. These are, it's a very serious activity. If you do not have enough stickers at your table, you can't find stickers at your table, steal some from the next table. It is totally fine. So, as you know with PARC, we like to introduce an element of mix and mingle into our activities. So once you've got your stickers, take 10 seconds to look at your sticker and learn the activity on your sticker. So I think we've got some heel digs in there. We've got some chicken jacks in there. So I see someone practicing their stretches. I love it. Good job. What you are going to do is in a minute, I am going to cue the music. We're going to play the music. I want you to move around the room. I want you to dance around the room, right? Just really feel the beat. We're going to kick the energy up a notch so that you go into your next session energized and ready to go. When the music stops, I want you to find somebody with a different sticker than yours. introduce yourselves, and then you are going to do the activity on that person's sticker, and they are going to do the activity on your sticker. Does that make sense? We got it? Find 3 new people, maybe that you haven't met yet, or maybe someone that you connected with on day 1 or 2 that you just want to say hi to again before we end. And do the activity on each other's stickers. All right, so if we can cue the music, we'll give you 15 seconds or so to move around. You can do walking lunges if you want to get really, really into it. Maybe grapevine your way across the room. I don't know. Get creative. All right, find a partner and then teach each other the activities on your stickers. All right, I see some really good stretching going on in the middle of the room here. Good job. Somebody got the squat jumps. I feel sorry for you over there. All right, move around the room again. Keep it active. Get creative in how you move around. Okay, find your second partner of the day. Who have we got? Say hi. Remember, it's important to introduce yourselves before you start challenging each other to chicken jacks. Good job. I see some really good form in the chicken jacks right in front of me there. All right, we'll do one more round. Cue the music. Find your last person of the day to connect with. Okay, your last partner of the day. One more activity before we move on into the next session. Okay. I thought you were here to like kick me off the stage.
No, I lost my partner.
Oh. I love people I can see doing this.
Okay.
Oh, stretching.
Got the music?
Nope, we're done.
Okay.
All right, thank you very much. I hope you feel a little stretched out and re-energized for the afternoon. As I said, those are our 50 fitness activities, lots of fun. If you want to learn more, you can come see me. I'll be around for the rest of the afternoon. And enjoy the rest of the conference. Thank you.
Thank you. Okay, thank you. I was doing the jumps. They got tiring after a while. Okay, everybody, I'd like to call you back to your seats. And then we'd like to start with the next portion of the show. Now, those of you, before we go to the plenary session, I would like to, those of you playing the topic game, we have the password for the last plenary session, and the topic passcode this time is the word Ottawa, all in lowercase. In case you're wondering the reason for that, 2 of our plenary speakers come from Ottawa, so that's the rationale for using that one. Okay, now we'll move on to the plenary session. As I told you, what was really good, the global challenge we're having this year is migration. And we'd like the theme to be immigrant and refugee health, collaborative efforts in providing support to achieve success. We have 3 terrific speakers, and the moderator for this afternoon's session is Dr. Penny Sutcliff. I think Penny's known to everybody here. Penny is the medical officer of health for the Sudbury and District Health Unit. She's and she'll be the moderator of today's session. I'd like to call on Penny to come up, and then we'll proceed with the and she'll proceed to do the rest of the introductions. Penny.
Do you need this or this? Can I use this? Okay. Good afternoon, everybody, and we might need to call in some of our colleagues who are still doing their fitness and perhaps eating break outside right now. I too would like to welcome everybody to this final plenary session, Immigrant and Refugee Health. And what a perfect way to close these 3 days of reflection on local solutions to global challenges, and really considering the roles of what public health can play, contributing to what are often very big and very overwhelming issues. So I'm eager to hear from our speakers, who I know will speak from their long-standing and their recent experiences in welcoming and supporting new Canadians with a focus on refugees. And while we take in what they have to say, I would like to invite everybody to think about the broader context of this session. Supporting immigrant and refugee health is important because in this work we of course address infectious and chronic diseases, we support mental health, and we promote a sense of belonging in Canadian schools and neighborhoods and workplaces. And this work is critical from a broader perspective. We're reminded of this broader perspective when we read the headlines, some of which are on this slide, from around the world. We're aware that the Canadian headlines are for the most part different from some of the headlines for some of our neighbors. But how do we ensure that this remains the case? How do we very explicitly put our values into action and ensure that inclusion and respect are the norm? There is no tolerance for intolerance, that there is no need to seek to build walls or to call out the other, because we understand, we all experience that there is room in Canada for all of us. So our panel speakers are working very hard to make this an ongoing reality. And if the measure of a society is indeed found in how we treat our weakest and our most helpless citizens, then our 3 panel speakers very much more than measure up. So I'd like to introduce our first speaker, Kevin Potty. He's an associate professor and practicing physician at the Departments of Family Medicine and Epidemiology and Community Medicine, and scientist at the Bruyère Research Institute, University of Ottawa. He's currently leading an international team developing the European evidence-based guidelines for migrant health. In 2013, he won the Gira Gupta Equity and Diversity Award for leadership for minority and underserved populations. In 2016, he won the University of Ottawa Article of the Year for his Canadian Medical Association Journal Guidelines, Caring for a Syrian Refugee Family. And in 2011, he led the Canadian Immigrant Health Guidelines. He's also held field positions, notably in the Republic of Georgia, Bolivia, Republic of Congo, Benin, Panama, and Nepal. So Kevin, over to you. Thank you very much for being with us today. Here you are.
Thank you. It's a real pleasure to be with you. I feel really very much at home in public health conferences. Our guidelines in Europe are actually public health guidelines for newly arriving migrants. And it's kind of interesting how within that guideline, we're finding there will be public health recommendations and community-based recommendations. And we hadn't really seen or done that yet. And I kind of think that this is something that's really important in the future, that we try to consolidate different guidelines that are emerging, and so that we're working together. I was lucky last month to be in Sri Lanka, where we had the second global consultation on migration, led by the International Organization for Migration and the World Health Organization, that led to the Colombo Declaration. And this was my first true experience to be sitting in rooms debating research agendas for migrant health, to be really with people from all countries of the world, I remember sitting next to someone from South Africa, Kenya, India. We had the UK, Canada, and we were all discussing what's needed for migrants. And so far, most of my work has been in the countries such as Western countries like Canada, Australia, US, and Europe. So I think that this is exciting to think that this is really going global, and we need to work together on these issues. And one of the key issues that I took away from the conference was to go back to the importance of universal coverage, universal health coverage. And this might sound like I think Canada, and I think we just had a nice presentation this morning that showed that in Ontario we had 100% health cards for our refugees. Now, of course, we have some other migrants that may not be getting their health cards, but let's just say the refugees at 100%, I feel is so exciting. I think that most countries in the world are not even getting close to that. I'm doing a lot of work in Europe, and they are really still struggling. So I think that we are really doing something right. But of course, there's another level. After you do the health card, and this is what we actually spent the whole session this morning talking about, was what does it take to build a system that works together to really ensure people get access to health care. So I think it was in the right direction, and the fact that we haven't solved everything is okay. I think it's an important challenge for the future for all countries to find ways to make their systems responsive and able to handle migrant populations. And the Syrians gave us a chance to actually to really challenge ourselves. So and I was happy to be part of it, and it's happy to hear about other people's experiences. Okay. I just have a few slides. My competing interests are just, I think, more intellectual. So when you actually work a long time developing a guideline, it's hard not to forget that that's what you believe in. But I'm just declaring that. This, when we put together this article, which was meant to be a supplement to the evidence-based guidelines, we had this situation where we were having people arriving, and within 1 month we were able to get peer review from 4 people, get the CMAJ to work with us to edit this, and have this published online early access. And I think this is kind of, I don't know if this means anything to you guys, but this can sometimes happen, but it certainly isn't happening in any other country. I wrote most of these guidelines as a contract for the European Union back in September, October, and they thought they were too nice for I shouldn't say that. Okay. Oh well. I said it. But so they paid me. They took and they made it into a 100-page document that included trench fever screening and a whole bunch of things that I refused to go into. And basically, it was buried. So basically, after ours was published, I sent mine back to Europe. It was being translated into Italian, Dutch, and so my European colleagues had nothing still. So therefore, they were able to use our guidelines published in Canada. Now, I think it could have been a little bit more Europeanized, but the European Union didn't want to go that way. But the difference is Canada and Canadians, we are ready for this. We're ready to do our best for refugee populations, and I felt that all morning as well. And it's very different than other places. Where do I look? Okay. I think I guess it wasn't presented at this field, but we really tried in these simple guidelines to focus on social determinants of health. You can see in the preamble, a lot of this is settlement, and this is where we need our partnerships with our community agencies. We believed that type of settlement will be the most important for good health outcomes, and this has nothing to do with doctors or nurses. And I believe we really did a good job on those aspects. And those aspects can also help prevent issues of post-traumatic stress. So we don't want necessarily, to be screening everybody. We would rather give them people a home, food, some friends, and training. And then if they're not doing well, definitely we need to look for mental illness issues. So at that point, that's what we were recommending. And then I think it's pretty clear we wanted, vaccination, and I think everyone is committed in public health to vaccination, so I don't have to even mention that. The TB one, we had the data from 650,000 Syrians in Europe. So it wasn't published, but we had the data, and it was incredibly small numbers of TB cases. So that kind of gave us an inside scoop as to what to expect with the Syrians. And so we were able to use that kind of data. They're not the exact same Syrians, but we know they're actually coming from similar countries, Syrians that are coming via similar countries. And then the hepatitis screening, and I thought it was interesting. We were worried that hepatitis C, because it's so strong, so high in the area, it may spread during a war. You don't know what happens. Egypt, I think, is at 11% prevalence. So we wondered if there's going to be some kind of problem, and in the end, there wasn't. So, and there's actually going to be new data on all, which I think is going to be really interesting, coming from the Canadian Pediatric Society and from our residents in Ottawa, where we looked at 660 Syrians. And I think, again, it's quite reassuring in terms of what we were doing and that we were very much aligned. We also wanted our guidelines to be used with our other guidelines because we didn't want to redo all 20. And so I think that the MOTH exam turned out to be an incredibly important one in moving people into dental care and using non-steroidal anti-inflammatory drugs, say instead of antibiotics, while you're waiting for dental care. So these kind of recommendations became very valuable. And then screening for visual acuity. This is pretty something that can be forgotten, but very important to get people glasses because they have to move around the city or they have to be able to read. So, and then there's these issues, I don't think I'm going to get into the details of them, around anemia. I think anemia was found, but there's some debates going around about G6PD, what the value of screening for that, but that's a long discussion. And developmental delay as well. I'm going to just acknowledge that there was definitely some certain people coming with developmental delay that required interventions. Our system was not really ready for that, and people that work in developmental delay acknowledged that they'd never had this number of caseloads from other countries, and so it's kind of a wake up for next time. How do we build capacity within that sector? I'm not sure I have time to do all of my slides, so I don't mind being pulled off at any time. But there's a kind of interesting article in, I think it's the New England Journal of Medicine, on global mental health. And it has a really interesting message when you think about that when people travel, there's certain things that we can change. We can give them a new coat. We can give them a vaccine to prevent a disease. We can treat certain diseases, often infectious diseases, and remove those as burdens of illness. But the mental health burden and the stigma that comes when you travel with mental health, we can't take that away. And I don't think anyone has figured out a way to remove this. And so this immediately is where we're having the different worlds meeting together. And this is why we need, I guess, local and global understanding so that we're not, overlooking one of the biggest challenges, which I would like to put forward today, is the mental health challenge with refugees. And I didn't hear that much mentioned this morning. I feel as a family doctor, this is the one area that we've done not very well with over the years. Even though we have some recommendations in our clinics, I don't feel we're doing very well. And this burden of disease that we can see here, it's a 33%, I believe. The same burden disease we see in developing countries is what we're seeing, I believe, with our immigrant and refugee populations. So to some extent, we're seeing the global mental health, and we're living with the same global mental health diseases and stigmas and challenges of access to care, challenges of treatment, and limitations on learning, limitations on that could limit them on getting employment. And I think, Morton Beiser last couple of weeks ago was kind of challenging me, and I feel, I think it's worth saying, is that we do a really good job, at least I feel like my clinic does, and a lot of our clinics, of doing a lot of our guidelines quite rapidly and efficiently now. It's really working. But the mental health side is not really getting done, and often it's being put off till later. So we used to think maybe this is okay because it's true, it becomes more obvious later, but maybe it's also preventing learning the second language, maybe networking. So this is something we may need to think about. Should we be doing more earlier for mental health to address this global mental health and stigma? I remember in Congo we had one psychiatrist, and we only had, I think, 12 psychologists. So it's very low. To be honest, in a lot of parts of Canada, we don't have a lot of resources. In Ottawa, we had no cultural psychiatrists until recently. So we had very difficulty finding a psychiatrist, and there was only one cultural psychologist. So this situation, I think, is not so different. So we're looking into ways of having, say, primary care, and there's also peer programs, and even maybe student outreach to start trying to fill this gap, because we don't have the numbers of professionals, and maybe the professionals shouldn't be used in the front lines anyway. So I think it just reminds me of, I was working with MSF in the Republic of Congo in the Pool region, and we were treating patients with HIV in a war zone these are almost low to no literacy patients. And at the time, everyone, of course, said, you can't do that. This is dangerous. They won't take their medications. This will not be successful. And I think, I don't want to take any credit for this, but I think the organization of MSF deserves the credit, because they saw this, and they said, well, we can't just leave those people at really 55 pounds, year old women, and then they were so weak they couldn't even walk. They were carried in on like wooden stretchers like you wouldn't believe. So this program took, basically probably 4 years to launch with local psychologists and to really develop the process. And that process was effective. They actually accepted treatment. And when they accepted treatment, their friends accepted treatment because they saw that they were getting better. And this is my challenge. I think we need to say that we have a mental health situation. I don't want to stigmatize people, but I'd say we're not really doing enough for the refugees in this area. And I think if we actually start to treat more effectively, we will potentially decrease the stigma. And a lot of conditions we find that the stigma can decrease with successful treatment. So I think of course, this is like we're hearing, I think we all agree we need to work together. We need to work with different professionals from psychiatrists to psychologists, social workers, and primary care, and then maybe even community workers to deal with some of these problems. I think I'm not going to talk too much about the collaborative care. I think there's a lot of shared care models in Ontario now, and we have one at my clinic, and I think it's a starting point, but a shared care model itself didn't look after our 220 Syrian refugees at our clinic. They only actually were able to handle 1 or 2 during a 1-year period. So that's okay, though. I think to me that's the reality. So it has to be the primary care people doing a lot of the bulk of the work. And then it was nice to have shared care to handle a few of the cases. I'm just going to go. So peer support is emerging. I believe there's a couple of programs in Toronto. So we know that there's a number of innovative programs around delivering services outside of clinics. So I still think my primary care is in the community, but I still think it's the clinic. So I think we can also go a step farther, and we do this in different ways. We're actually training our medical students community service learning program. We have, we've trained about 1,800 of these students in 13 universities now, and they see from, now it's a Beirut to Vancouver, but we've never done a mental health program until now. So with Dr. Morton Beiser, we're now doing narrative exposure therapy training so that the students, when they're in the field and when they find suicidal and other people, that they're not afraid to talk to people. And this always happens in our program, because if you're in people's homes, you will see things. And so I think I feel like for the first time we're starting to go there. But of course, we're trying to link those people again to, to family doctors or other professionals. But the students, I think, are really enjoying learning about mental health without any mental health words. So in narrative exposure therapy, it's all about a lifeline and hot memories and cold memories, and it's not about any kind of diagnosis or mental discussion. And so a lot of people respond to telling them stories, how they feel about their stories. And the students seem quite comfortable with that as well. Yeah, so I think the community outreach was my final point. So I think we have to look at this at multiple levels. I'm sure public health really could play a key role in this mental health as well. So we need to find different ways to support each other. So I think I'm not going to talk about that. This is just a reminder. I heard this, I think, again this morning. I really feel like the stuff I'm hearing at this conference is very much aligned with my thinking as well. But one of the studies that came out, I think, last month really emphasized that what people want for mental health is strong group-based social supports, a focus on practical needs such as acquiring, maintaining employment, language and literacy training, and access to care. So it's not necessarily a psychologist or a worker. They need their life to be organized and looked after. I think in this slide, this is a recent study, again from last month, that showed that, I'm not sure this is totally significant, so I don't want to overstate it, but that the home-based and the community care did better than the more official counseling approach. So I think this is potentially good news that we can have good results without necessarily having to use the time of our professionals to do this. So I just going to leave you with a few messages, but I think your conference is about integrating global expertise in local public health. So I think that I support that too. I think that I'm really interested in, can we get more for mental health? Can we go more toward the home? Can we kind of leave metaphorically our medical constructs, are more intimidating stigma areas, and that might be one of the ways to reach people with mental health problems. And then continuing to look after their basic social determinants of health, which I don't think anyone would disagree with. That's it. Do I go back there or stay up here?
Go back there and we'll call you back. Thank you. Thank you very much, Kevin. Our next speaker is Marion Ocala. Marion has been the Executive Director of COSTI Immigrant Services since 1987. COSTI is a community service agency that has been providing a broad range of services to immigrants and refugees in the Greater Toronto Area for the past 64 years. In 2016, COSTI was responsible for resettling close to 2,000 government-assisted Syrian refugees in the Toronto region. Mario has been involved in his community as past president of Social Planning Toronto and as a member of the board of the Toronto Region Immigrant Employment Council, the Ontario Council of Agencies Serving Immigrants, and the Catholic Children's Aid Society. Mario has also served on the Ministers' Roundtable on Fair Access to Regulated Professions for the province of Ontario. He's a recipient of the Newcomer Champion Award by the province of Ontario, the Queen Elizabeth II, the second Golden and Diamond Jubilee Medals, and the Calabria America Prize in recognition of his community work. Please join me in welcoming Mario to the stage. Thank you.
Thank you, Penny, and good afternoon, everyone. The public health sector played a key role in the resettlement of some 17,000 Syrian refugees who came to Ontario last year. And it's a real pleasure to be here with you today to tell you about that initiative. COSTI is currently housing about 120 refugees at the Radisson Hotel that arrived recently. Last week, I got a call from the physician at the on-site clinic advising me that there was an outbreak of norovirus amongst their clients. As I quickly learned, the noro is a contagious bug that involves vomiting and diarrhea. We were concerned about how the hotel management would react to this news. I suggested that we pull a protocol together before we informed the hotel manager. With the help of Toronto Public Health, a protocol was established, and Dr. Calford and one of my managers met with the hotel manager to explain what was happening and what needed to be done. It would only be a slight exaggeration to say that I sat by my phone waiting for a call from the hotel manager to advise me that we were getting our notice of eviction. I was sure he was going to make protecting his business clients a priority. Instead, I got a call, an email from Dr. Calford advising that the manager responded professionally and immediately offered to put a team together to wipe the elevators down and the common areas. As of last weekend, we have not had another case of infection. This is just one example amongst many of the goodwill and collaboration between settlement agencies, health professionals, civil society, and the institutional community that has resulted in a remarkable achievement: the successful resettlement of 25,000 refugees across this country in the span of a few months. I want to focus on that collaboration because in some respects it addresses larger health issues related to the social determinants of health. Poverty, isolation, stress are all common ground for refugees, and the community's response helped to mitigate these realities to varying degrees. Let me give you some context. COSTI has been what we call the RAP agency, RAP being the Resettlement Assistance Program that the federal government funds for organizations to resettle government-assisted refugees. Another acronym, GARS, Government-Assisted Refugees. COSTI, over the span of last year, resettled 2,300 Syrian refugees. What the RAP services are, basically when the refugees arrive, they come to us directly. We have a reception center. When we have an overflow situation, we go into hotels. And we provide a range of services that make sense for someone who's coming directly from the airport to us, and that makes sense in a temporary facility. So obviously, we set them up to get their OHIP card, social insurance number, open a bank account, provide them with orientation to our education system, and so on. And the most important thing during that period of time, typically 3 weeks in a temporary facility, is the housing search and helping them to settle in the community. These are the typical services, as I say, in terms of the RAP services. But with the Syrian refugees, things had to change for a variety of reasons. Prior to their arrival, there was much planning. All three levels of government were involved in an unprecedented way in terms of the communication and the kind of services they were making available. There was much work in trying to set up contingencies. You may recall that we had 2 military bases that were on standby. And as a result, my personal concern was, from our experience in working with the refugees, that we have people coming from war zones, and we're housing them on military bases. But this may have been the only option for us. So I called the Toronto Arts Council and Toronto Symphony Orchestra. They quickly jumped on this. They wanted to send in performers to make the basis a more welcoming environment for the Syrian refugees. But fortunately, we did not have to use the military bases because we had one thing on our side. It was the dead of winter, and the hotels were yearning for business. And so, also fortuitous during this intensive period was the government's decision to bring the privately sponsored refugees first. If you recall, they started arriving in December of 2015. So throughout that whole month, most of the arrivals, thousands, were privately sponsored refugees. This gave us more time to set up our planning and build our capacity. Their profile, the privately sponsored refugees, what we were seeing at that point was that 52% were single, 49% had post-secondary education, 60% spoke English. In other words, these were people with high human capital, which would make it a lot easier for us to resettle them. Unfortunately, this threw our planning off because we were somewhat unprepared for the different cohort that the government-assisted refugees presented. The GARs were a much different group of newcomers. You see, the privately sponsored refugee program is in many respects a family reunification program. Sponsors sponsor refugees based, on recommendations from others in the community, family members, friends. And so the privately sponsored refugees have connections here. And by extension, they have higher human capital. In contrast, the government-sponsored refugees are selected by the UNHCR for their vulnerability and then referred to Canadian visa offices. As a humanitarian initiative, there is a sensible balance between the two streams in providing protection to refugees on a continuum of needs. What we found with the Syrian GARs was that only 1 in 10 spoke English, about 12% had any post-secondary education. There were many, many medical issues. At the Plaza Hotel, where we were housing about 600 of these newcomers, we had 1 or 2 ambulances making runs through the hospital every day even though we had an on-site medical clinic. The Gar families were much larger. They averaged 5 to 8, and families with 10 children were not uncommon. In fact, 56% of the government-sponsored refugees were aged 14 or under. These profiles also meant that we would have more difficulty finding housing, and they would end up staying in the hotels longer than we had anticipated. And so this created a new challenge. During the month of January, by mid-January, we had 5 hotels and our own reception center populated with GARs. We had anticipated the need for on-site medical services early on, and in fact, we had meetings with the Ministry of Health, the LHINs, community health clinics, Toronto Public Health, and refugee health advocates all in one room, and we quickly established the health clinics at all the hotels. Some of the sites included midwives and pediatric services, but I will return to the health services later in my presentation. While the health services were established, what we discovered in terms of the challenges of this particular cohort, that there were other challenges that needed to be addressed. The one that jumps out is the kids. At the Plaza Hotel, we had 260 children under the age of 14. The hotel was their playground. They would ride the elevators all day. At dinner, they would put sugar in their Coke and get totally wired for the rest of the evening. Crayons became a detestable weapon by us, sought out to be eliminated because the hotel walls became a canvas for these children's creativity. You know, in Syria, pigeons are a popular hobby. And there was a 10-year-old farm boy, Adnan, who spent much time in the back parking lot of the hotel baiting pigeons. This clever boy managed to grab one, and he brought it into the hotel all excited about his new pet. As soon as the adults saw this, they tried to convince him to release it, but there was no way he was going to part with this pigeon. This turned into a huge circus in the lobby as about 30 people tried to wrestle this pigeon away from Adnan. But there was no way he was going to give it up. Finally, they took it off him, to great amount of tears on his part. But 3 days later, Adnan is seen coming down the hallway, but this time he's got a Canada goose under his arm, holding it by the neck and wrapped. And what was so amazing was he's heading straight for the kitchen. This is a farm boy who knows what geese are good for. Again, there was a huge ruckus as everyone tried to convince him he had to let the bird go. You know, I just grew to love these children, the spunk and the spirit that they presented. However, as someone who ended up with a huge bill from the hotel at the end, realized we needed to find more constructive outlets for these kids. And the institutional response was amazing. Both Toronto school boards came through and they started busing the kids to local schools. Toronto Children's Services set up a children's center at the hotel where 4 other children's service organizations and hundreds of volunteers provided regular children's programming. The Toronto Public Library came through providing books and storytelling activities. For adults, the YMCA came through to do the language assessments, and we set up English classes for them. Typically, this doesn't happen until they leave the temporary facilities, and so on. And so the institutional response, as I say, was great. Civil society also responded with offers of help. This happy child here received her backpack and a gift box from Canadian children who collected and delivered these gifts to the Syrian children. Also, the civil society, in terms of, we had 500 volunteers who provided interpreting, escorting, to appointments, housing search, and befriending of the newcomers. A group organized itself as the Clothing Drive, and they managed all of the donations for us. This picture is of a pop-up shop that they established at one of the hotels. The Syrian Canadian Foundation, another group of volunteers that organized themselves, basically provided this children's programming that were very popular at the hotel. Here you have the children are being introduced to Indigenous culture by these Indigenous drummers. And of course, face painting was always a very happy activity. So the community came together to help out. I just want to touch on the health services, obviously. As I said, the hotels had we had a health clinic at each hotel. And, you know, considering that these hotels were operating in the dead of winter when most of the newcomers were more or less confined indoors, it is a credit to the health professionals that the only infectious outbreak we had was a short-lived case of pink eye at one of the hotels. Otherwise, everything went well. Toronto Public Health organized immunization clinics at the various hotels to catch all the newcomers going through. We would provide a banquet hall. Toronto Public Health would send a dozen nurses, and all newcomers had, you know, basically a vaccine. About 4,000 doses of vaccine were administered by TPH. Oral health issues were really widespread. Toothaches requiring immediate attention were common. Fortunately, again, Toronto Public Health had a mobile dental bus, and they brought it to the various hotels, and they conducted 500 interventions through that particular bus. In addition, they set up a small fund for dentures. Midwives became necessary members of the clinical teams. There were many pregnancy, and some were diagnosed as high risk. For many pregnant women, it was their first visit with a health professional. Family planning was an issue that was consistently raised by the women, never by the men. In fact, it came up in our cross-country coordination calls with many humorous attempts at trying to address this issue by various settlement agencies. At the clinic's request at the Radisson Hotel last year, the Toronto Public Health set up a workshop for the women, but none of them showed up. At the Travelodge Hotel, which we jointly operate with Rexdale Women's Centre, the director of the center got fed up with all the complaints from the women about family planning issues and the lack of response by the men. So she headed out to Shoppers Drug Mart. She filled a shopping cart with condoms, walked through the store to many an amused look, and delivered them to the women. I guess she was thinking that if you can't break through the cultural and gender issues, then at least put a suggestion in the women's hands. I think this is an issue that will come up by these women in doctors' offices. What was really surprising was the number of men that smoke heavily. This is a serious issue for the obvious health implications, but also for the pocketbook. But as Dr. Rashid said, it's really a tough time in a refugee's life to be suggesting to them that they should quit smoking. However, it was interesting that the men noticed that smoking is socially unacceptable in Canada, and they asked for help to cease smoking, and Toronto Public Health set up a series of workshops. A tremendous job really was done by everyone, public health, the clinics, and so on, in providing a seamless service to the refugees in the hotels. Post-hotel, all of the 1,900 refugees that we saw in that first group that arrived between end of December and end of February are in their own homes. We have services following up with them, supports from local agencies. About 87% of the adults are in ESL classes. All the children are in school, and they all have been connected to a family doctor. Basically, in concluding, I want to say that I want to return to my comment about the social determinants of health, in that the goodwill and collaboration by the institutional community and civil society have contributed to a welcoming community. And it's much easier and certainly less stressful to integrate into a welcoming community than in one where you are made to feel that you are not accepted or welcome. For refugees, it's the gestalt, the whole experience that contributes to their health and integration, as Dr. Potty was saying earlier. And the community did come together for this initiative. This picture is of the last families to move out of the hotels last May. It was a bittersweet day for them as they were launching into a new future while having to say goodbye to friends that they had made in their stay at the hotels. I think that it was this communal response, public health, and everyone that made it a successful initiative, and I thank you for your contribution to that. Thank you.
Mario, thank you very, very much. Our final speaker is Carolyn Pim. Carolyn is an Associate Medical Officer of Health at Ottawa Public Health. She serves as a medical advisor to Ottawa Public Health communicable disease and immunization programs. She's an adjunct professor at the University of Ottawa School of Epidemiology, Public Health and Preventive Medicine, and Carolyn has worked as a public health physician in Canada for over 25 years at the local, provincial, territorial, and federal levels in epidemiology, communicable disease control, immunization, health promotion, and cancer prevention and screening. Carolyn was also the director of the Calgary Refugee Health Program from 2005 to 2008, and more recently coordinated Ottawa Public Health's response to the influx of Syrian refugees 2015 to 2016. Welcome, Carolyn.
Thanks, Penny. I don't know how I won the lottery. Last speaker, Friday afternoon. Everybody wants to leave. I'm going to try and be as quick as I can, and hopefully I won't speak too quickly. But I'll try and actually skip through a few things to respect your time for sure. So I'm just going to talk briefly about Ottawa Public Health's response to the Syrian refugees. Those of you who are at the session this morning on Syrian refugees will have seen a number of similarities between the responses of many health units, and Mario's talked a little bit about Toronto's. So I'm not going to spend a lot of time in that, but I also want to talk a little bit about highlighting some of the lessons that we've learned and the need for flexibility and tailored approaches as we move forward and learn from the experience as well. So many of you will be familiar with this probably fairly pale picture right now, but this is the National Collaborating Center for Determinants of Health, their framework for public health roles for health equity. And when I think about our public health response to the Syrian refugees, we certainly had activities in each of the sectors, but mostly we focused on the yellow and the blue, the modifying health interventions and the partnering with other organizations. So I'm going to just focus on those for now. So in Ottawa, just as in many other areas of the province, we had a coalition called Refugee 613. For those of you who don't know, 613 is the area code for Ottawa. So in October 2015, this coalition was formed. It included the usual suspects that you've heard from other coalitions: citizens, settlement agencies, sponsorship groups, community partners, health, and so on. And there was a specific health task force that met regularly, and within that health task force there were two subgroups, one which was focusing specifically on mental health, and one which focused on primary care, and public health was most closely involved with the primary care subgroup. In terms of some of the interventions, these are very similar to what many other health units that had to accept, that were involved in accepting the refugees, had to had to be involved in. Now, I use the words temporary lodging sites because some of you may be familiar with ILSs, which were the interim lodging sites, which were the military bases that were supposed to have been activated if local responses were overwhelmed. Well, local responses were overwhelmed, but guess what? They didn't open those. So we just, not we, but certainly the word temporary lodging sites was used. And certainly there were many challenges. You can see there some of the typical health protection functions, but also oral health and some of the other ones, as Mario mentioned in the Toronto response. Just as one example specifically related to immunization in the temporary lodging sites, one of the things, and as Mario mentioned, that was unexpected was the low literacy level of the GARs in their own language. So notwithstanding the fact that we had fact sheets and consent forms that had been translated into Arabic, these were not helpful at all if people couldn't read in their own language. So we had to adapt quickly. We were very fortunate that we had Arabic-speaking staff, both at the receptionist and the public health nurse level, who could step in, and that really made a huge difference. One of the best examples of adapting services on the fly was our oral health program, which really deserves huge kudos for their nimbleness and their agility, to use Mario's word. So our initial approach was, again, hearing that there were very large oral health needs in the population. Our initial approach was to go into the temporary lodging sites and screen the refugees and refer them to the settlement workers. But what we quickly found, and not really a surprise once you're in the middle of it, is that the settlement workers were overwhelmed, and also the usual pattern of referring to community dentists was also didn't have the capacity, especially in the language department. Transport was another issue, and so we really had to regroup. And so basically, the team went back to the drawing board, consulted with our community oral health advisory committee, and came up with a very innovative short-term response plan. I'll just say that. I'll just go on to the next slide, and then you'll see. We established dental clinics. So typically, Ottawa Public Health doesn't have clinics on Friday mornings. Hey, we have a free morning. We could have Syrian refugee-specific dental clinics. Who's going to staff them? Let's call out to the Ottawa Dental Society and see whether we can get volunteers. Well, I think the big thing on this slide is look at the bottom of the volunteers there. We had almost 60 dentists and dental assistants volunteer, and they contribute over 1,000 volunteer hours to provide care to the Syrian refugees, almost 70 of whom had significant dental findings on the screening program. So that means we changed our screening. We just screened the day before the clinic. The LIN was very instrumental in helping us organize transport from the hotels to the clinic, and these clinics were extremely well received by both the refugees and the volunteers themselves. So some of the success factors that others have spoken about are certainly the collaborative nature of it. We also had a very supportive LIN that provided funding in very key areas, so supporting extra nursing time in the hotels for primary care, providing additional funding for interpretation, including post-response, extending availability of interpretation to family health teams, and as I mentioned, they also provided transportation. Others have mentioned, certainly in this session this morning, that activation of the incident management structure within Ottawa Public Health provided structure and communication channels and coordination channels that were really critical in terms of the success. Some of the things we learned that I'm hoping we can take forward in future responses is to clarify the roles as much as possible and strengthen the relationships before the response. So one of the takeaways is, now that we've got all this experience with the response, now that we've strengthened our relations, for example, with the settlement sector and with the primary healthcare sector, let's build on that, make sure that we don't lose those connections and networks. Also, I think that we certainly, I think someone said this morning, you go to bed and you think you've got a plan about how we're going to respond to this. You wake up the next morning and everything's changed. I think that yes, we have to be nimble, but in our planning, I still have this feeling that I think that perhaps we might have done some scenario planning and not just automatically accepted what we were hearing about. They're all going to be GARs. They're all going to be privately sponsored refugees. They're all going to have pretty good high literacy, and just ask those wicked questions. What if? What if they're not like that? What if? And try and anticipate some of those things in advance. So in terms of how we might build on the experience, one of the things I want to highlight here is, two things actually. The first thing is that Refugee 613 is looking at again, building on the experience and trying to develop an intersectoral response plan that's scalable. And part of that is looking at each of the partners and seeing what their capacity is, but not only their current capacity, but what their scale-up capacity is and what the tipping point is. Because one of the things we found in this response was, even if you threw money at it, you still didn't have enough people to actually do the work. So we need to know what those constraints are in advance so that we can plan for those. The second thing I want to highlight here, it relates to the provider capacity building in mental health. So in the spring of 2016, so after the really intensive phase in responding to the refugees, we're still hearing about the mental health needs and providers' discomfort with addressing some of those mental health needs. Our mental health team did outreach to the community partners and identified a need for provider capacity building in the area of mental health, and we developed a mental health promotion workshop to increase the comfort of community providers, not for clinical care, not for clinical mental care, but really just sensitization, difference between mental health and mental illness, broad assessment of if someone is struggling, what some of the resources are available, what some of the stigma issues are that I think Kevin mentioned about mental health, and some basic things around suicide prevention. So this was really helpful. We had over 60 community partner participants in some of our workshops, and further ones in the fall also had great participation. So now I want to go on to just a couple of vignettes to illustrate some of the common themes that extend. It's very easy for people, not very easy. That's an understatement. It was a lot of work, but let's just. Rolling up your sleeve when something is acute, is really urgent. Everybody jumps in, and the Syrian refugee response was an excellent example of this. But how can we bring that forward? The issues still remain. Refugees are coming every day, and they don't necessarily have the supports and the intense response that Syrian refugees might have had at the time. So, what are some of the things that we can take forward with that? So, this is a case of a 5-year-old girl whose family had been in Canada since 2012. So, not a new family to Canada. Had traveled overseas, and 3 weeks post-travel was diagnosed with hepatitis A. The initial investigation was relatively straightforward, but about 3 weeks later, 2 of her contacts were symptomatic. Now, the point I want to raise here is that both of these on separate occasions were seen in the emergency room. They were both jaundiced, but because of language difficulties, the message that the emergency room staff or medical staff got was that these children had been immunized, when what the family was trying to communicate is that they had been contacts of hepatitis A, and that might have very much made the response of the physicians quite different had the language barrier not been there. That also resulted in a delay in reporting of this to public health. And as many of you who have been involved in responses to hepatitis A, we had one of the children was in a school, the other in a kindergarten, the other one was in a daycare, and there were lots of contacts, and many with large families. And particular to this response is if this wasn't enough, we found that 80% of the contacts required interpretation. So some of the traditional ways of responding to a large contact follow-up that we have done and have experienced before didn't work in this situation. So even if we had interpretation for telephone contacts, when you have a family of 10, it's very difficult to have a telephone conversation with an interpreter. We also found that with this large number that the capacity for interpreters was stretched, because even if we had many staff who could make those contact follow-ups or even in-person follow-up with people, we didn't have the interpreters to do that response. So some of the observations in this particular case is that it was probably largely preventable, and this is very common. I think Kevin can probably speak better to this than I can, but certainly this family had no pre-travel immunization. I don't know whether they had a pre-travel consultation, but within the index case family, they had 5 notifiable diseases, not the least of which were 2 cases of measles. And like with the hepatitis A, the measles was also missed. At least one of the measles cases was missed, and was missed by an infectious disease physician at one of the hospitals. The parent presented with fever and a rash and a recent history of travel, and measles was very low on the differential diagnosis. So we have a lot of work we still have a lot of work in that area, and I'm sure many of you will have similar examples of misdiagnoses like that. So the last thing I want to just talk about is another vignette about how although we have our traditional public health roles, and in this example is a health protection role in terms of following up in tuberculosis, we also need to be thinking of our clients as individuals and supporting them in whatever way we can. So this is a 19-year-old Syrian refugee. He did have timely diagnosis. He developed TB 6 months post-arrival. But about 6 weeks into his treatment, his direct observed therapy, or his DOT worker, was concerned about his mental health. His mood was very flat. He was asking for medication to make him numb. He didn't want to be in Canada. We can't assume that every single refugee that comes here, especially children who come with their parents, want to be here. His girlfriend was still in the Middle East. So we did a rapid consultation with our mental health and immigration sector partners, building on the networks that we had built during this Syrian refugee response. Found out that he was not acutely suicidal, but he did refuse counseling. But some of the supports that we could provide that really, I think, did make a difference for him was, first of all, we had an Arabic-speaking DOT worker. She was able to provide support to him and his family, and go way beyond some of the things beyond the strictly health protection TB management. We also provided him with a phone, and this was a significant thing in terms of increasing his independence, increasing his connectedness to other people. Previously, his father was the only one with a phone in the family, and any communication that we had to do with the young man had to be through his father. So the phone, although it seems pretty simple, was a significant factor. So in summing up then, I think we need to adapt the approaches that we have to meet individual and group needs, and it's really important to check your assumptions both at the system level and at the individual level in terms of looking at the situation that you're dealing with and how you can react to that and think about it ahead of time as well. We need to build our staff capacity for intercultural work. Our partnerships need continuous nurturing, and we need to continue to advocate for things such as interpretation services and some of the really important social determinants of health, such as important housing, adequate housing, language learning, and some of the really important factors that really are critical for newcomers' adaptation to their new life in Canada. So I'd like to thank the people on this slide who contributed to the presentation, and I also want to thank the teams at Ottawa Public Health who rose to the challenge of the Syrian refugees. And most especially, I'd like to thank newcomers themselves for the true inspiration they provide with their courage and their resilience. Thank you.
Carolyn, thank you very much on behalf of all of us and to all of our panel speakers. We unfortunately will not, in order for people to be able to return home in time, we'll not have time for Qs and As. However, I will ask our panelists to indulge them if they can maybe stay near the front if people would like to come up to them individually and ask questions. I think that would be great. I just want to say that my reflections on what I've heard, and would that we had longer to reflect on this important subject, is that many efforts, as we are aware, have been underway and are going underway to make sure that Canada is welcoming and is inclusive, and that our headlines remain as those that I showed at the very beginning. And I think that we've had some tremendous examples of work to ensure that Canada is welcoming. And I think up to all of us to think about how we can continue to make sure that those headlines remain the same and that we remain a welcoming and inclusive country. So thank you to our speakers, and thank you very much for your attention on this session, this important subject this afternoon. Thank you.